the reason this one got added is just like we talked about last night in Skills Lab. This one is typically taught with perioperative, but because that did not, I wanna make sure you get the information. There is no prep work for the section because typically the prep work that I do when I teach periop is mixed in with skin integrity. So we pulled skin integrity out, it's its own thing. The things I would like for you to focus on the most will be on staging of pressure ulcers when we get there. So stages 1 through 4 plus the unstageable, your staging of pressure ulcers. And then your, what they call wound healing or intentions, wound intentions. So the two different resources, we'll name those different things for you. But those will be the major areas. A lot of this is gonna be review content from 112 for things that we would look for to promote skin integrity, people who might be at risk for impaired skin integrity, and then some nursing interventions that we can do to promote the best skin quality there. So going back to our learner objectives, our main points are gonna be the functions of the skin, what's the skin for, what are some of our common findings. Like I said, we're gonna mention some other skin conditions. We're not gonna focus on those for the sake of today because burns, for example, you'll do either next semester in 114 in basic emergency or 211 in advanced emergency with a little bit more severe burns, traumatic burns. We're also gonna talk about cuts and abrasions, things like that, but we're focusing on pressure ulcers. That's the big one because all hospital patients could acquire a pressure ulcer. And then finally, those treatments we talked about so that you can ensure that we are doing everything we can to promote their skin to stay together. So, what is your skin for? What is the point of skin? What are you supposed to do? What's it, why? Yeah, protection, why? What's it doing?
It protects your body from any pathogens that can go inside.
It's keeping things on the outside out, things on the inside in, put it simply. And so, if you didn't already know, there's bacteria that live on your skin. That's fine and dandy every day of the week, but when that cut's happened and it gets into an area that it is not normally living, it will take over. So the example I like to think of here in the South is like kudzu. Kudzu was originally a great idea for land erosion, but there's nothing like over in Asia where kudzu is from. Pandas love kudzu and pandas eat kudzu. And so, but you put kudzu somewhere that there's nobody to eat it, kudzu everywhere, right? It takes over. So same kind of deal with your skin. So your skin is the panda, if you will. It's keeping the kudzu away. Then you've got your sensory perception. So obviously there's a lot of nerve endings in there that help you have, that's one of your senses is for touch. And so you have pressure receptors in there as well as thermal receptors that'll pick up on hot, cold, sharp, things like that. So helps to protect viable organs and things like that. We need it for vitamin D synthesis because that is the most common way you get vitamin D is from your sunlight, so it crosses your skin and it is absorbed there. And then temperature regulation, so through, we talked about influent electrolytes through that water barrier and sweating and things like that, we can regulate, or through your hairs, creating the goosebumps to help regulate your temperature there, closing those pores off so we keep our heat inside. Questions about functions? Kudzu? Really? Okay, you'll have to Google that picture, but it is kind of like an invasive ivy, if you want to think about it that way. Lots of it back in my hometown. People would even make kudzu jam. We could talk about that forever. But moral of the story, it's an invader. It doesn't belong to America because in the South, the lands are that red clay erodes and easy to go. So they originally used it to try to help anchor the soil and keep it from eroding, but there's nothing here to eat it, so it spreads like wildfire. It's a vicious vine. All right, so factors that can influence our integrity. You've got two, intrinsic, extrinsic. Intrinsic are the ones that I semi can control, but the extrinsic are going to be factors that are presented to the skin. So intrinsic are going to be things that I'm responsible for, like age, genetics, chronic diseases. We always talk about diabetes being one of the main factors, because when I say diabetes, you say no. Feet, thank you. Y'all, my twins remember from last semester, when I say diabetes, you say feet, because that's where we're looking. And then Mr. McCarty talked to you last week about, or a couple weeks, whenever this was, because my timeline's off, about some vascular issues, so PVD, PAD, all of those things can lead up to, because we know that you need adequate blood flow to help perfuse the tissues. And so any of those kinds of factors would be considered intrinsic. Extrinsic is going to be like pressure, friction, and shearing, so your immobile patients, or when you're boosting up patients in the bed and we grab pressure points instead of using a draw sheet, or your patients are sitting at an angle in the bed and slide down and it creates a skin fold or an extra layer that's going to get corded off from vascularity and will break down. Excessive moisture, so when in doubt, dry it out. Less layers is better. We can introduce them to chemicals, get chemical burns, radiation exposure for your cancer patients, or radiation from the sun. All sorts of things will break that skin down. Moving on, so the most common skin disorders, notice that pressure injuries is slightly bolded. I don't know if you can tell because it's all white, but pressure injuries is your bold one because that's our main focus for the evening. And so we're going to talk a little bit more about staging pressure ulcers, and we're also concerned with those people. So what are some common reasons people get pressure sores? Who comes to mind patient-wise? What do they look like? So immobile. What about age? Usually you're older. Why? Because why are your older people at risk? Because what breaks down as they age, or we have, well, think about their skin gets nice and thin, so we don't have that padding or cushion anymore. Those deeper dermal layers go away. Also, who's at risk? Your thin people. Again, they don't have padding either. So think about your common surfaces, usually just your large flat bones. So think about some of those. You can list some there. That would be your common places to look. So that's why we go back to 112. You gotta flip your chicken, because most of those places are on their backside. Scapula, coccyx, sacrum, things like that. In between the gluteal folds, all that. Then we have our intentional wounds that we're going to focus on as well. We're not going to talk about our, oops, we got in a stab fight or something like that. Those will be for later in emergent. But we are going to talk about purposeful wounds, the ones that we cause either by puncture or laceration from surgical cut, and how we're going to describe those for intention. So those two are at the top. And we just mention them because it is in the book for your integumentary section. But if you are looking for time cut, I would cut those bottom two. We're just mentioning them because they're in there. Because you're going to email me, Mr. Fuller, burns and infections are on there and you didn't say anything about them. Yeah, that's a later semester. So you can skim over those sections. Pressure injuries and intentional cuts will be on there. But we're most going to focus on staging and those healing stages. So things that you're going to look at with any good skin assessment, your color, temperature, moisture, texture, turgor, all the things that you're used to doing there. So what color would we not want? There's two colors that I just don't ever want.
Black.
I like that because I don't have blood flow. What's my other one?
Purple.
Well, it's bruising, but we're going to ultimately put red because it might be infectious. So red and black are going to be two signal colors to you. So yay, Opelika, we're going to be our mascot for wings, right? Red and black. Nobody? Okay. Thank you, somebody. All right. So then, what about temperature? What temperature do you want? What's your baseline?
Warm.
I like warm, and I like most of the time, we call it dry. I don't mean bone dry to where they're ashen or losing skin flakes when you take off their socks, things like that. But we do want them to be dry. And then texture, smooth. I like smooth texture. I don't want a whole lot of bumps and lumps and dents and divots and all those sorts of things. So smooth texture. And then turgor, elastic is where we're going. Yes, perfect. There's your baseline. That's what we're looking for. All right, assessment tools. There's going to be a lot out there. If you had to pick one, I would go with the braided scale. I will not pick your brain on the specifics of the numeric and what those comprise of, but I do want you to be familiar with a Braden score of 15 or less would equate to them being at high risk for skin problems. We need to put them on a skin care plan to preserve their skin. Anything over 15 is kind of nursing judgment, but 15 or less, you better do something because they're going to break down. Nutrition's looked at, their skin moisture, their ability to ambulate, there's different sections, but you can Google what that form looks like to kind of get a gauge of what it's looking for. Most of it's gonna be from your visual inspection of the skin. And then, 15 or less would indicate that you need to do something. And then there's some colors down there at the bottom, or things that we talked about that might be signs, that something's going on. So the one I wanna focus on that might be a little new to you is that delayed healing, which is gonna segue perfectly into diabetes just shortly. Why might diabetics have delayed wound healing? I like that, circulation's a big risk factor. What's their other problem with a diabetic? What do they have in their system? Sugar. And why does that delay wound healing? It does, and so because of that bacterial growth, my body spends its energy fighting off the invader versus healing the tissue. So yes, we are focused big time on delayed healing with your diabetes. Many more populations you're worried about, but that's a good sign that we need to intervene. And then infection, we're looking for that red hot and drainage. Please put purulent. We revisited that last semester. We're gonna say it again. We're gonna do purulent and not pus. Got it. Moving on. Nursing interventions, things you can do about it. Prevent it in the first place, so we don't even have the problem. That would be the best. So turn your patients, flip your chickens, get them moving. Ambulate. We're gonna push hydration. So what's your normal hydration? 2 to 3 liters a day. And so when they're in the hospital or have a skin risk issue that we need to bulk it up, you're gonna buff it up by a liter, okay? So 3 to 4. Nutrition, we're gonna talk on a different slide about some boosters, but let's go ahead and name some. What's your main component you need for skin or tissue healing? Protein, I like that. There's a couple more we're gonna add in the mix on another slide, but I like that you know that one. Skin protection, so we can get all into things about sunscreens, padding bony areas. Have you been to a clinical yet where the units put the Mepilex dressings or the foam pad dressings on their bottom as a preventative? I know that Baptist South does that. If we get to go there, you'll just get one from the Pyxis. They actually look like a little heart, a little foam heart, and they go right on their sacrum. If I see your tailbone, just go ahead and put a Mepilex on it because I know it's gonna break down in bed. That's right. You can't, so we're preventing them. I'd rather spend the money to prevent it than for the hospital to pay for the aftercare. Moving on. We got the wound care itself. So cleaning, and there's all sorts of different things out there. We could talk about debridement, where they'll actually go in and irrigate and make culture. Dressing selections, they have everything from basic gauze to silver impregnated, topicals. So we could spend hours talking about all the wound care options that are out there. But in your nursing orders, ensure that your wound care nurse or provider has given you details of exactly how they want that to go down, and then whether or not the procedure should be sterile. We're going to talk about at what point those procedures turn sterile. Sam? We do perform, we are allowed to perform wound care at East Alabama. I will go ahead and mention to you while we're in our turf and not theirs, they do tend to do them non-sterilely for ones that should, in my opinion, be sterile. We go with what they do. Like we're not gonna rock the boat. We just carry out whatever they've been doing. That's how we do it. Now, in the back of your mind, we're gonna talk about how we would set up and go about for sterile once we leave the room. The other things that I would like for you to be aware of is most of the time, if they're invasive, we're gonna talk about wet to dry dressings really quick. So why do we like wet to dry for invasive? First off, your internal tissues are wet, so I want to maintain the moisture so that the internal tissues don't dry out. Number two, you're trying to generate granulous tissue from the inside out, because obviously your epithelial tissue will heal faster than your dermal tissue. And so what's gonna happen if my epithelium closes off over that dermal layer and it's not healed up down there? It's got a pocket, so it's gonna abscess and assess, and I agree with that. So what happens is, think that bacteria loves dark and wet and warm, all that. So if I close off with that epidermal tissue, I've got a hole down here in that dermal layer that's gonna fester and hold that bacteria and skin cells and junk that falls down in there. So we need to heal from the inside out. We like wet to dry dressing so that granular tissue will bring it from the inside out. Pressure injury prevention, we got more of that on a later slide. And then education hygiene, because we know keeping skin clean and dry so that bacteria doesn't build up. Even at a minimum, if they don't want a full bed bath, y'all heard of the airplane bath or the hot spot bath or different things. So fits and tail, under the wings and around the tail. Okay, at minimum, because that's where your most common bacteria are gonna harbor that will spread. Need to ambulate them, and then if they cannot provide self-care or do those things for themselves, that gets you to thinking about the social services side of things. We need to get them somewhere that can care for it, because if you just send them home and they can't do their foot care, what's gonna happen? They're gonna lose their foot. So I'd rather you set up, a home health visit or something like that than them knowingly going home not being able to care for themselves. All right, so the treatments that we can do, nutrition is our biggest component that we're gonna provide. So making sure that if they have skin problems, that we boost protein. And then our other two that we like here is zinc and vitamin C, because those are great for cell growth and cell replication. So that's their function, as well as what do you see zinc and vitamin C on right there, Natalie Naylor? What's in your bottle? Yeah, emergency. So what are those two things also good for? Because they're in your emergency. Immune response. So yeah, so not only with the zinc and vitamin C am I helping cell replication, I'm also helping fight off potential invaders. It's an immunobooster. Love it. Then non-pharmacologic, all those topicals, everybody and their mom's got a topical at clinical, don't they? Everybody's got the zinc oxide or the Sam.
Is the zinc, is that the orange?
It is, the most popular brand is an orange cream, but Desitin is a zinc oxide. I would like for them to eat it, but if they're not able to eat it, I'm gonna put it on the wound. And so that's when it moves up to that topical or lotion. So good thinking there, you're connecting dots. Hydrotherapy, don't ask me on that one, that one's in the book. I have not seen that done. Do I have anybody that's experienced hydrotherapy for wounds? I have not, it's listed. Negative pressure, that is a very common one. You got, Drew, you got a hydrotherapy?
No, I was thinking about the bed at the hospital, it's like the sand beads that vibrates or whatever.
Right. Y'all remember the thing in the hospital that used to, so the book says it's supposed to help stimulate or promote circulation, but it's not a aggressive manual massage. But I've personally not seen that, but I listed it because it's in the book. Negative pressure, that is what you probably have heard called a wound vac, where they'll take the foam packing and actually vacuum seal it. So what a better way to heal than to cut off all air supply from any potential bacteria, as well as to draw out any drainage or anything that's collecting there. And also the vacuum helps to promote that granular tissue growth because it's pulling it up towards the surface. The last one is bariatric therapy. So hyperoxygen,
Bariatric chamber.
Yep, bariatric chamber, bariatric therapy. They'll put you just in a high oxygen environment, and that gives those tissues that may not have the best vascularization. So this is very good for your PAD, PVD, diabetic foot ulcers, things like that, because if that tissue does not have adequate circulation, you're artificially giving it that circulation and oxygen that it needs during that therapy. And so what's the drawback of bariatric therapy is that they have to go multiple times for 30-minute to hour sessions, several days a week. So talking about expense, transportation, like is that feasible for their lifestyle? Yes.
Outpatient.
Bariatric, yes. We will not do that acute care. It is an outpatient setting, but very, very common. Jesse, I know went to wound care. Did you get to see any bariatric? How? And so, can you kind of share with them real quick? Because what does I have not seen their, apparently they bought a new chamber.
Longer than 30 minutes, they were in there for like 2 hours.
Yeah.
Did you have to have like 30 minutes to go in and then 30 minutes to come back
To
out?
depressurize. Okay.
You have to take breaks every 15 minutes and breathe normal air.
So are they putting them entirely in there or just the
Yes.
limb? Okay. The ones I'm accustomed to at Russell, they have where you literally put the extremity in and it's almost kind of like a little rubber seal that'll hug your arm, and so if it's like, AV fistula is for the dialysis patients, or sometimes ones that we'll see, like, it's an old site and they're trying to heal it up on that side and start a new one, they'll literally just stick their arm in and it's 30 minutes to an hour. But that makes sense if they're submerging the whole person.
So it looks like a tube, and then they just go in it and they seal it behind you.
So would
The whole bed goes into
So the whole person, okay. What is it saying?
So your cloth will go down behind you.
They are supposed, I think, unless, like, I haven't seen their model, you typically clear or some sort of plexiglass. So you shouldn't be caught because you can still see versus a.
You can't hear from the inside out though, and if you talk to the speaker, you talk to you.
That depends. I would do better with that than like the actual MRIs that actually seal you all. Those are fine, I mean.
They have
we'll get
somebody
this-
there last time, I said for freshman year, trying to get it, so you don't lose it, but they're trying to get it for,
Then your last treatment group is gonna be your pharmacologic, so obviously antibiotics if it's infected, antifungal if it's a fungus, steroids to help fight inflammation, so we're gonna look at other skin conditions in later semesters, that are, immune. So lupus comes to mind, has a lot of skin issues related to, inflammation, so steroids are great for that. And then obviously pain management for like your burns, deep tissue injuries, all those sorts of things may be exposed to. All right, start this one. This is one of your big slide takeaways, gotta know through the exam. Is your wound healing stages or wound intentions. So I'm gonna give you what I call a buzzword. It's definitely a little more complicated than that, but if you have a blackout on the test, I always like you to have a little buzzword to help lean you to a direction. So primary intention is that I intended to cut them open, I surgically closed them, they stay surgically closed, and the skin heals naturally in that suture line or staple or however they adhere the skin. It's an intentional cut, intentional suture, stays healthy. Your secondary intention is going to be where they are left open because maybe it's so deep that I can't, either cosmetically or for the way that the tissue, where the tissue is to heal, I can't close them because that top layer may grow back together before the bottom layers. So secondary intention, they are left open on purpose and heal from the inside out. So we would pack those wounds wet to dry, and over time, they would heal up from the inside out. Then last is a tertiary. It kind of has two in there. The first one, it says it's initially left open, but it's due to a complication. So it's either infected, and I don't need to close the bacteria in there. So if you want to think about maybe like a bowel perforation, which that's a little different. I can't think of a good one off the top of my head, but we're going to use bowel perf because that'll kind of make sense. Instead of immediately closing the bowel back closed and having the bacteria out in the peritoneum, they may leave them open for a moment and then close them over time. They're going to wash them out. We know that they'll do an abdominal wash, but I'm just using that for an example to get you to think about if there was a wound or an abscess that was super deep, instead of closing it up and I know that I might have remnants of bacteria in there, I leave them open and then at a later date close them. But the problem with the tertiary is that there's a known problem. Also in the tertiary umbrella is what I call oops. So I intentionally closed them that started off as a primary and they either popped their sutures or they dehisced or something bad happened or they developed an infection and I either A, had to reopen them or B, they reopened themselves. And because of the damage it did, I just leave them open and let them heal from the inside out. So tertiary has got two. So it's gonna be a known infection and we leave them open. It's from a complication, not from a healing standpoint, or an oops complication. And so I've got pictures on the next slide for you. Up at the top, I cut them, I did what I needed to do, I sutured them closed, and then they're gonna have that little hairline scar because everything's nice and pretty and approximated. All right, so this one might be from a trauma, a car wreck, something like that, but I don't have a nice, pretty symmetrical cut. It's kind of off, misshapen, things like that, so there's not really a way to gather that tissue and make a hairline, suture. So, I'm gonna heal it from the inside out, so that your granulation tissue is gonna start pushing up and healing from the inside out. But notice that it is going to leave a scar tissue or scar pocket there. So that skin density wise, if you're palpating them, might feel different if it was healed by secondary intention, because the scar tissue is gonna feel different than the traditional tissue. But I'm healing it from the inside out, maybe because of the shape or because, there's nothing to grab, a hold of to suture it close. And then finally is your tertiary. We had whatever type wound we did, but I'm kind of worried about infection if I close this off, or is it going to be infected? And so same deal, it is healed from the inside out, but I can eventually suture it once I'm over the whatever the problem was, infection, drainage, nothing to grab, I need some more tissue before I can close it, something like that, I need some grafting done. And then ultimately can get a suture to help close it. But there was a problem, is why it was delayed closure. Secondary intentions are not delayed closure, they just heal from inside out over time. Questions about this one? This is usually the biggest part of the struggle, is getting those different intentions. So if the physician, let's do it this way. The patient has a stage 3 pressure ulcer, and we are going to do daily wet to dry dressings on it. That would be what type of intention or wounding? Right. What about we had a planned knee surgery, the physician amputates on the knee or cuts on the knee, inserts the new kneecap and closes them shut. Alright, so if you had an example, you just label it, that one will strictly be knowledge based on what type of intention are we healing by. Feel okay? Alright. Pressure ulcer staging, your other big slide, and so we'll talk about those. So I have some pictures coming up for you, but I'm gonna again give you a buzzword or a little helpful hint that might help you identify in the question where you're going. So for stage 1, it's called non-blanchable redness. And so if for a second, I want you to everybody grab a pointer finger and you're gonna poke the back of your hand. Notice it's gonna turn white, and when you lift up, it should refill with blood and go back nice pink tone. Well, with a stage 1, you're gonna have an area of redness. If I do the same thing, the little blanch test, it does not turn white, it stays red no matter what I do to it, it is red. It might even feel a different temperature compared to the surrounding skin, and that means that we have started to develop a pressure in which we technically have one. But at this point, I can reverse it. So you want to catch them at stage 1 because I can reverse it. Once we move to stage 2 and 3, we now have treatments to do for it because we have an acquired. That's where the hospital gets in trouble. We don't like these, but JCO's kind of okay with them because we can hit the rewind button. Once we go here, we have to pay for all the aftercare associated with it. So stage 2 is going to be what they call open, or it's developed a blister and it's eventually going to burst. But it is where that top layer of skin has either blistered up from the pressure that your body has tried to start creating a cushion with that blister, or the blister has ruptured and that layer's gone and you see the beginnings of the dermis. And so it's going to be shallow or an intact blister, the book says. Stage 3, we have dug a little deeper, and now we're into the subdermis or hypodermis tissue. But it extends through, but we do not yet see muscle, bone, or tendons. Yes, ma'am.
So what is the stage, so the patient doesn't have a blister? How can I put it? So you know how like if you was to scrape your hand or something?
A skin tear?
Kind of like that, but what stage would that fall in? Would that be 2 or?
If it's caused by pressure, stage 2. Yep. Stage 3 is a little bit deeper, and you'll see that. So I like to think of stage 2s are going to kind of look more dry unless it's the blisters ruptured. Stage 3 starts to look damp, because you're starting to get down into blood flow and serous tissues, the sweat glands, all of that's exposed. So stage 3s look shiny, in my opinion, but don't put that, because that's just my own opinion, that's not really textbook or factual, that's just my perception of how we see them. Stage 4, we are down now into muscle, bone, tendon, all those layers. So at what point do you think this turns sterile?
3 years.
You can argue 3, but stage 4, please do those sterile, because like, if you're on bone, bone's very vascular, you can give them osteomyelitis and cellulitis, bacteremia, septicemia, all that really quick. Stage 3, facilities will argue whether or not they need to be sterile, and there's not really any solid research to argue, but stage 4 is definitely sterile. And then unstageable, the reason it's unstageable is not due to the depth. We may think it's a stage 4 because it is down, but due to either eschar or slough, and we'll look at both of those, I cannot visualize the wound bed to actually see. Even though due to depth, I'm sure it's a stage 4, I can't see the wound bed to verify that. So here's some examples. All right, so looking at just a plain old picture, stage 1, if I poke on him, he stays that color, he doesn't turn white, it stays the same. I can reverse it, start doing your turning schedule, patting that area. Nepilex, if it's over a bony surface, boost their protein, so that's where we're gonna add on those protein, and my brain's going blank. I'm trying to think of it's the pro-flavored syrup, you may know it, Josh. That, come on, brain. But it's a little syrup. Can I put somebody to research that in the background? It's a little great protein syrup. They come in other flavors now, but that's the one that sticks out in my brain. Who? Prostat, that's the one. We have those at the hospital, you will see Prostat. And with Prostat, it is not good on its own, so typically if you wanna market that in a grape juice or a cranberry juice to make it a little more palatable, that would be good. There's some of those. Now, Liquicell's also got a division of dressings in addition to those little protein shakes. So, stage 2, we are still just in the dermal layer, but that blister has popped open or it has blistered up from pressure. Stage 3, we're down into hypodermis. Stage 4, you're all the way, see straight to the bottom. So your actual patient pictures. So heels, how many times have you heard floating heels? So here would be a stage 1 on someone's heel. So what's the cream y'all put on heels at Clinical a lot? Ventilex, I love that one. There's several other ones, so no right or wrong answer, but you're trying to do something on there to help make a barrier because we're about to go. Those boots, Prevlon boots, we can float their heels just on a standard pillow, all sorts of things there. Stage 1, no, bless you. Stage 2, that top layer is gone, but notice it looks kind of dry, flaky, it's just still in that upper layer. Where stage 3, we've started to get shiny, because we're getting there. A lot of people want to confuse that for tendons and stuff, but that's just that hypodermis tissue, so we're good. And then stage 4, we actually have tendon, muscle, bone there in thick groove. Last one is your unstageable. That's the eschar. The slough looks exactly the same. So this would be an example of the slough, the yellowing fibrous tissue. It's the same thing, same appearance, except it's yellow instead of black. But I can't see the wound bed because your body's trying to create a covering to protect it. So it'll just cover over. So now we have to go back to what we were worrying about with secondary wounds, because if I close off that top layer, we have to worry about abscessing. So sometimes your providers will remove that eschar or slough to actually get that bed back open so we don't abscess or harbor bacteria under the eschar. All right? So key things that you can do. If you didn't already have these in your back pocket. Reposition, typically you're every 2 hours. The book says every hour in bed or in a chair, but we said in 112, if they're in a wheelchair, every 30 minutes would be the best, but an hour is at least your minimum if they're seated. pressure relieving surfaces, so all the foams, pillows, specialized mattresses. Has anybody seen like the airfield beds or the Clinitrons, P500s? All these, there's the little sand beds, that fluctuate little sand to try to promote circulation. Skin care, clean, dry, if they're incontinent, open to air is just fine. I'd rather change out of Chuck's pad than you to get some, incontinent dermatitis. Nutrition support with those things, your vitamins or your zinc and vitamin C, in addition to push extra fluids. And then patient education, how we can help promote their health at home. Self-care, how they can take care of it, and if they can't, we'll get them the resources. Questions on skin, always. Yes, ma'am.
I know it. So, with the picture you showed, would that not kind of be a deep tissue injury, or what would that look?
Are you talking about like the deep purple? Those
Yeah.
are not super common, but I'll show one to you. It's where surprisingly the skin has somehow, survived, but so like the skin's still intact, but most of the time those are related from trauma. I don't know of one from just sitting pressure, unless they are just sitting all the time. I don't know how the skin stays intact, honestly, for those. Most of the times when I've seen these, it's been from trauma, a deep impact, and so the deeper tissues. But what's gonna be your clarifier? So if it's from trauma,
The skin is in.
well,
Or is it blanching?
blanching. So the different, if it's related to pressure, that blanching component will be your, if it's just a bruise because I got punched in the gut versus it's from pressure, from just immobility, breakdown, loss of vascularization, that kind of thing. Sitting. So that will help you clarify that blanching.
So that would kind of be unstageable too.
It would just be called a deep tissue injury. It wouldn't even be called pressure. Deep tissue injury if it's purple or bruised. But we typically will not have a whole lot, most of the ones that you will come in contact with will look like this, unless they've had it for a long time and it may have some eschar for protection, and that'll get surgically removed, and we continue to heal it. Any more you can think? So if you had a picture, could you stage a pressure ulcer? And if you have a little scenario about a patient's wound healing, identify primary, secondary, tertiary. That's the big stuff I want you to take away from today. Granted, yes, there's other stuff in the book, but the two that I'm worried about related to perioperative are those two. Feel good? I got 4:45. Take a little breather, stretch your legs, go do something. We'll pick back up at 5 o'clock with some diabetes.